Greetings. My name is John Ruzek. I'm the Vice President of Engagement for the University of Minnesota Alumni Association. Welcome to today's webinar, a COVID-19 conversation with public health experts from the University of Minnesota's School of Public Health. And thank you to all of you who are joining us live and online today. Should be a very good discussion, apologies in advance that I'm broadcasting from my home, but I think everybody else is at their home, and so we'll make the best of it as we go along here today. So first, I just want to say thank you to the members and donors of the University of Minnesota Alumni Association who make online initiatives of the Alumni Association possible. And if you'd like to learn more about the Alumni Association, you can visit umnalumni.org. We have some other upcoming webinars here in April, and actually next Monday and Tuesday, some good ones on April 13th. A faculty member from the College of Continuing and Professional Studies, along with the School of Social Work at the University of Minnesota, will be talking about adult children who are caring for aging parents during this time of COVID. And then also, we will have on April 14th, a faculty member from the medical school talking about the mental health toll of COVID-19 and how you can all take care of yourselves and one another. So if you'd like to learn more about those upcoming ones, you can see those at umnalumni.org/virtual. Also, a very big shout out and thank you to the School of Public Health at the University of Minnesota. This week is actually National Public Health Week. And so in the midst of one of the most challenging public health crises of our lifetime, it's more important than ever to celebrate public health. And this year's National Public Health Week's theme is looking back and moving forward. And today is the first day of the annual celebration as far as recognizing National Public Health Week. We did not try to coordinate the webinar for this date, but it's serendipity at its best. So thank you to everyone, faculty, staff, alumni of the School of Public Health, because we're really appreciative of your efforts, and you're going to be hearing from 3 of those faculty members later this webinar. Just a quick thing on using Zoom. Many of you have logged in. If for any reason you'd like to switch over to a telephone option, you can dial 646-558-8658, and then all you have to do is enter that specific webinar ID that's listed there for this particular webinar. Questions and answers are welcome, and you can use the Q&A button on your spacebar to ask a question. I will admit we will probably have way more questions than we're going to be able to cover. We will try to do our best, and because we know the topic is of interest to folks. So I would now like to introduce the 3 faculty experts from the University of Minnesota School of Public Health who have joined us for the webinar today. And each faculty member has a specific area of public health expertise that can inform our understanding of the current COVID-19 crisis, from food safety to rural health to epidemiology. And we're grateful to each of them for sharing their time with us today. Dr. Ryan Demmer, Dr. Craig Hedberg, and Dr. Carrie Henning-Smith. And with that, I'm going to stop sharing my screen, so we'll go to our video view. But first off, I would like, we're going to let each faculty member introduce themselves for about 5 minutes as far as both their background and also what's on their mind around COVID-19. And we'll start with Dr. Ryan Demmer.
Hi, well, good afternoon, everyone, and thanks for taking the time to join us today. Thank you also to John and Heidi for organizing this and making it possible. So as John noted, my name is Ryan Demmer. I'm an associate professor in the Division of Epidemiology and Community Health in our School of Public Health. And my general research interests are at the intersection between infectious and chronic disease, with a particular emphasis on how microbes can cause chronic diseases like heart attacks on the one hand, but I'm also interested in how pre-existing chronic diseases such as cardiovascular disease or diabetes would increase a person's risk for developing an infection such as COVID-19. So given that background, it's a pretty natural progression for me to start initiating some research initiatives relative to COVID-19. And as John mentioned, I'm just going to take a few minutes to talk about these issues and research interests and share some of my thoughts in terms of specifically the interplay between COVID-19 and cardiovascular diseases. So we have really good evidence that COVID-19 infection has a very high mortality rate among people with pre-existing cardiovascular diseases. Some of the initial reports from China and Italy, for example, suggest that as high as a 50% mortality rate occurs among people infected with COVID-19 who also have coronary artery disease, for example. So that's 1 in 2 individuals, which is extremely high. And the reasons for this are not well understood, unfortunately, at the moment, but there are 2 possible speculations, which I can say a few things about. So the first just has to do with an elevated inflammatory response. We know inflammation is an important part of the underlying pathophysiology of cardiovascular disease. And in the presence of a potent immune stimulus, such as COVID-19, the ensuing immune response can simply overwhelm the system in people who are already compromised. It can lead to the rupture of atherosclerotic plaques, it can cause arrhythmias, and otherwise lead to poor cardiac function, leading to heart attacks and even heart failure decompensation. So that's one reason. Another reason that these individuals could be more susceptible, and this is far more speculative, but there's a lot in the media about it, is the use of certain cardiovascular medications that have the potential to increase risk of infection and possibly increase viral load, make the infection actually worse. This is a very conceptual idea based on our knowledge about the biology of COVID-19 infection as it relates to the mechanism of action of these cardiovascular drugs. So it turns out that the biological targets of these medications is quite similar to the cell surface receptors that SARS-CoV-2, that's the virus that causes COVID-19, uses to unlock the door to our own human cells, get inside those cells, replicate and perpetuate infection. So as a result, the thinking is that the use of these medications might actually make it easier for the virus to infect and replicate, and therefore make the disease actually worse in individuals on those medications. However, I don't think we should be too fearful of this at the moment. To date, there is not strong evidence that this is actually true, despite the underlying biological plausibility. And much more importantly, we already know that cardiovascular disease has been the leading cause of death in this country for about a century. So as a result, the risk of death related to stopping a medication known to be effective in preventing heart attacks and strokes is a much greater threat to public health at the moment than any hypothetical risk related to COVID-19 infection. So the upshot is that at this time, there are no recommendations to stop use of these specific medications, and your best advice is to be in contact with your primary care physician and follow the advice that they give you. So what I just talked about was a brief overview of some direct effects of COVID-19 on cardiovascular disease. I also wanted to mention the indirect effects that could significantly impact people who never even become infected. And the key issue here is that in the United States alone, a heart attack occurs every 40 seconds. It results in over 800,000 heart attacks annually, and that's just focusing on one particular form of cardiovascular disease. And there's no reason to believe, and we know for a fact that these events unfortunately won't stop during COVID-19, and there's good reason to believe they may actually accelerate. And some of my colleagues will talk about some of the reasons that could be true. And for this reason, we want to make sure that we control the spread of the infection. We've all heard the phrase flatten the curve repeatedly in the last several weeks. And one of the main reasons we want to do that is to prevent hospitals from becoming overwhelmed so that they can't deal with not only COVID-19 patients, but sort of patients suffering from other non-COVID-19 illnesses, such as heart attacks. So finally, on that note, I just wanted to say a few things about a project I'm starting to help us better understand the control of COVID-19 that hopefully will help us to flatten that curve. So the project is going to look at testing asymptomatic healthcare workers for the carriage of SARS-CoV-2. And by asymptomatic, I simply mean people who don't look or feel like they're sick yet. They have no signs or symptoms of illness. And we believe that asymptomatic carriage is really important because it's now known that the virus can be transmitted even when you don't look or feel ill. And early data suggests that up to 50% of transmission is from someone who appears to be healthy. So in the average person, it might take 5 to 7 days for symptoms to develop. And you think about healthcare workers, they're coming into constant contact with potentially infected individuals because of their service on the front lines in this pandemic. So that puts them at increased risk of becoming infected. And then they can't socially distance. So they're coming into contact with many other people through that approximately 1 week asymptomatic period, increasing the chance that they're spreading to others. So we hope results from that study will help inform the infection models and maybe help us do better testing in healthcare workers to reduce that risk. So I'll stop there and pass it on to my colleague, Carrie. Thank you.
Thanks, Ryan. I am also really happy to be here today, and I have a feeling that you'll get from the three of us a flavor of how varied and how interdisciplinary public health is, which I love, and it also means that we can address COVID-19 issues from a range of perspectives. So I think that will come across. I'm an assistant professor in health policy and management here in the School of Public Health. I'm also the deputy director of the University of Minnesota Rural Health Research Center. My research interests are largely in health policy and health equity. Within that, I focus on rural health, and I focus a lot on emotional and social well-being. So I focus a lot of my work on social isolation, loneliness, mental health. And because of that, COVID-19 feels as though it's hitting my research head-on in two very particular ways. One, through rural health, and two, through this sudden discussion that everyone is having about isolation and loneliness and what it means to not be with one another physically. So I'll take just a couple of minutes to talk about both of those research areas and where I see COVID-19 intersecting with them. First, for rural health, rural areas are not yet really experiencing the worst of this epidemic, this pandemic. This has been hitting big metropolitan areas first, places like New York and Seattle and New Orleans. That said, it appears to be only a matter of time before we see the spread infiltrate into rural areas across the country. It's starting to happen. I worry it's going to continue to happen and only get worse. Rural areas have some advantages in that people, just by definition, don't live as close to one another. They're a little more spread out physically. So the social distancing is a little easier in rural areas, but they have a lot of challenges, a lot of disadvantages as it comes to fighting this pandemic. For one thing, rural areas have much more constrained access to healthcare. Rural hospital closures have been a focus of media attention for several years now. We know in the last 15 years, 170 rural hospitals have closed across the country. There's no indication that that trend is going to stop anytime soon. And in fact, just last week, I saw the news of the first rural hospital closure that was attributing their closure to COVID-19. It was a hospital in rural West Virginia. And because rural hospitals are being asked not to conduct elective surgery or even routine procedures, routine visits to keep their healthcare workforce and their patient population safe, which is good practice, it means that they're missing out on valuable income that they rely on. Many rural hospitals are just barely on the margins of making it from day to day or month to month. So the healthcare capacity is reduced, it's limited in rural areas. Rural areas also have different economies, different industries. Rural areas have recovered less quickly from the Great Recession that we had just over a decade ago. I worry that they have a less robust infrastructure to handle whatever might be coming economically down the pipe for this. And people in rural areas tend to work in different jobs than people in urban areas. In many places, it's harder to work remotely. I'm working from my home right now and I'm able to do that. I have a job that accommodates it. I have great access to broadband internet. That's not true in all rural places. It can be really hard for people to work remotely if you're working in agriculture or mining or manufacturing or another job that doesn't translate to the home setting. can also be really hard if you don't have reliable access to broadband internet. And on top of all of that, Ryan mentioned the intersection between infectious disease and chronic disease. We know that COVID-19 is more dangerous for older adults, but also for people with underlying health conditions. Almost every chronic condition that you can name has higher rates in rural areas. People are more impacted by those. Rural areas also are older on average than urban areas, and both of those put rural areas at critical risk from this pandemic. So that's rural health. Social isolation is also manifesting in really unique, potentially troubling, and potentially really heartening ways through this pandemic. I think because we're asked to stay away from one another, to physically distance ourselves, and I like this language of physically distancing rather than socially distancing. We can still socialize, we can still call one another, send a letter in the mail, Zoom, do what we're doing now. We can be together with one another in a myriad of ways right now, but we're asked to not be with one another physically as much as possible. And for a lot of people, this is raising new thoughts about what it means to be isolated, what it might mean to feel lonely, especially if you're living alone, if you relied on getting together with friends, going to a place of worship, going to community events, all of these things that we can't do very well right now. So I think we're getting an acute taste of what it feels like to be isolated, to be lonely. But I want to remind people that for some people, this is a fact of life. It's not something that just came with this pandemic. It's something that they've always lived with. My hope is that because we're all getting a little taste of this, we can appreciate how important it is to address social isolation and loneliness and community connectedness for everyone once we emerge from this pandemic. I'm going to stop with that and pass it along to my colleague Craig, but I look forward to our discussion today.
Thank you, and I also appreciate the opportunity to be with you this afternoon. I'm Craig Hedberg. I'm a professor and interim division head in the Division of Environmental Health Sciences at the university. A lot of the work I do relates to food safety. My background is from public health practice, surveillance of foodborne diseases, and my real interest are in how we can use our surveillance data to improve prevention practices. And that's a lot of what's going on right now in terms of COVID-19 as we try to understand what's driving this pandemic and translate that learning into better prevention and control practices. But as it relates to foodborne illness, of course, one of the great concerns is people have as to whether COVID-19, the coronavirus, can be transmitted through food. And we can say that there's absolutely no evidence that this coronavirus is transmitted through food. But there's a lot of questions that come in around the whole process of obtaining food, either going to the grocery store and getting food or ordering out from restaurants and getting takeout food. And what are the implications for bringing packages of food into your house? And is there an environmental risk, or to what extent does this cause a risk for transmission of COVID in that household setting? And I think that for the most part, you know, the potential environmental contamination of packaging materials coming into the house, whether they be on food or mail or other things, are really quite low. And when we look at how this virus is transmitted, you know, Ryan was talking about the receptors for the virus that it uses to infect our cells. Our respiratory tract and lung tissue is very rich in those receptors. But when we start looking at, you know, food we eat, the dynamics of that potential virus transmission are very different. So this is not a virus that is designed to infect us through our gastrointestinal tract. It's really a respiratory virus. And so when we look at environmental contamination, the issues really are how would that virus get from a packaging material into our respiratory tract? And that brings us to the hands. And the hands are the most direct route of transfer. If we touch an environmental surface and we do pick up a virus and it's on our hands, then, you know, washing our hands becomes that barrier from the movement of that virus into our respiratory tract. And so that's really been one of the major drivers for that recommendation that people wash their hands. And so if you're out at the grocery store and you're buying food and you bring packaging back into your household, really washing your hands after you handle that packages and before you go to prepare any food or do anything else is your best prevention measure from that standpoint. So you can certainly wipe down food packages that you bring into the household. I think the benefits to that are going to be small in terms of your risk of disease transmission, because the risk of transmission from that setting is low already. The one thing we want to make sure is that you don't do things to your food that are going to cause problems that don't exist right now. So people are looking at what type of chemical products can disinfect, be effective disinfectants and kill the virus on environmental surfaces. And when we're dealing with food products, we want to make sure that we don't apply chemicals to the food intending to kill the virus that could then be harmful to us. So, so in terms of, you know, wiping down packages, if you want to use like a commercial wipe, there's not really any likely problem with that. But again, it's not going to probably reduce your risk a lot. For things like fresh produce, we don't want to apply, you know, chemicals onto the produce that could be on the produce when you eat it. And so that's the main thing, is we don't want to create problems where problems really don't need to exist right now. The other dimension to this that is worth thinking about is that you know, all of our normal food safety issues that we do worry about are still going to be present. And actually, one of the things that could be happening now is that because people are at home more, there are more people probably cooking meals at home and cooking things that they aren't used to cooking a lot. And so we want everybody to be aware of good food handling practices. And this is really an opportunity, I think, for everybody to study up on how to prepare foods properly, making sure that we're cooking our meat and poultry products, that we're not having cross-contamination of raw food products from of the ready-to-eat products from raw, and that we have good sanitation and hand washing in our food preparation areas as well, because we don't want to see an explosion of foodborne illnesses because people are handling foods in unsafe manners in their own home. So I think those are some of the issues that we've been dealing with on my end, and I'd be happy to answer questions.
All right. Well, thank you so much for just the brief updates. We had a lot of questions submitted in advance, and I know a lot of people are submitting questions through the Q&A button here on Zoom. So continue to, if you do have questions, please submit them on the Q&A button. The one thing I did skip over that I'm just going to share again is School of Public Health. I did a quick short link, z.umn.edu/SPH April 6, and that goes to the School of Public Health Strategic Initiatives page, which covers quite a bit on COVID, has a link to a great podcast series that they've just started doing. I think there may be 3 episodes in, that is really, really informative, and then also connecting back to the Infectious Disease Center as well. So if you haven't checked that out, it's also listed z.umn.edu/SPH April 6. Otherwise, Google School of Public Health, University of Minnesota, also University of Minnesota Alumni Association has landing pages, which is consolidating a lot of U-wide stuff as well. So in that vein, I'd like to just first, because we've gotten a few of these questions, is there's lots of different news sources out there, different things on social media. When you look at kind of just assessing where the best news or websites, as far as just assessing the basics or the changing nature of COVID, what are the websites that you rely on? And I'll start with Ryan.
So I rely on the CDC's website. I rely on the Minnesota Department of Health website for good factual information about basic things like masks, hygiene, and what the numbers are. I've also looked to the Johns Hopkins website for their case counter, if people are interested in looking at that.
Yeah. All right.
I second all of those, and also want to put in a plug for all of my colleagues at the School of Public Health. Beyond the few of us that you're hearing from today, we have some experts who are doing incredible work. Dr. Eva Enns is helping with a lot of the modeling, or leading some of the modeling that's informing the state level decisions here in Minnesota. Dr. Mike Osterholm is a leading infectious disease epidemiologist and is a real important voice in all of this too. I think you can hear both of their voices in the podcast series that you just mentioned, John.
One thing that came up and obviously started changing late last week was the CDC's recommendation that folks wear masks out in public. And so we've had a handful of questions just as far as just with questions about why that recommendation was made by the CDC and how that might help flatten the curve. Carrie, would you be willing to take that one?
Yeah, I wish we had Craig here for this one.
I think he just dropped off, but we'll try to get him back.
Yeah. So my understanding of this is that it's meant to help prevent you from spreading those droplets that we know contain infectious material. And really, I believe many of the cotton masks are less about protecting you from infection, more from protecting your risk of infecting others. Ryan, do you have thoughts on that too?
Yeah, I believe the current recommendation is for non-surgical grade. The big thing we want to avoid is people getting a false sense of security that if they wear a mask, they're fine, and they stop the physical or social distancing, which is the #1 thing we can do right now in the short term. That's, bottom line, physical distancing or social distancing is the way to go. The other big issue and concern a lot of people have about mask recommendation is that it will lead to competition between healthcare workforce and citizens in the population. People on the front lines can't social distance, they have to go to work. I'm in communication with a lot of local clinicians, one in my neighborhood, and he said that if they were able to use proper PPE, which they can't right now because there's such a short supply, they would be out of PPE in a day. So we really have to avoid any sort of competition in that regard. And the other thing you'll hear about face masks is it's a little bit of a mixed bag from time to time, because what it does is it encourages people to touch their face more often, which can be problematic also. And Greg, we were just talking about face masks. I don't know if you wanted to say anything about face masks and the recent recommendations.
Yeah, I'm sorry, I lost my connection for a minute here. But no, I think the issue with face masks, particularly some of the homemade cloth masks that people are recommending, they don't have a really good efficacy at reducing the spread of virus, but probably in some settings, they may reduce the amount of virus that is asymptomatic person, is shedding. So there probably is some basis that if everybody out in public we're wearing these things, it might reduce the potential virus load. But frankly, the data aren't all that strong in favor of that. And I think the main thing that we want to continue to recommend is staying away from direct contact with as many people as you can. That physical distancing in public settings is really where the gain is in reducing transmission from this virus.
Mm-hmm.
John, can I say one more thing real quick?
Absolutely, go ahead.
Linking the face mask thing back to trusted sources of information. Carrie had mentioned Michael Osterholm, which I'm glad she did. And he leads the Center for Infectious Disease Research and Policy, or CIDRAP. They have a very good website that's loaded with great information, factual information, real time. And I think they also have some information on face masks. So that's a good resource.
Mm-hmm. Here's one question, like we were talking about, like as far as like websites and Minnesota Department of Health, the CDC, but just as far as kind of the state's kind of response to COVID, I think in some of the pre-calls before this webinar, we were talking a little bit about if the Minnesota Department of Health is planning to do any tracing of the disease in the population, or how that might be unfolding. And I can't remember, Craig, was that in your area? I forget.
Well, I think the Minnesota Department of Health obviously has been doing follow-up with all of the cases that are being reported. And I know that they have done contact tracing with cases. I don't know how, given the volume of cases coming through, I'm sure that presents a great challenge in terms of trying to trace everybody down. But I think that, between the work that investigators like Ryan are doing and the health department, we will see over the next few months a number of studies that come together to try to really look at the question of how widespread in the population this virus got. And I think the development of the antibody tests, will ultimately be very useful. And so I would anticipate that we'll see collaborations between investigators at the university in conjunction with public health officials to really build those studies.
Mm-hmm. Carrie, I have a question that came in from an attendee kind of on the rural Minnesota question. And she says she has a family in a county which has 0 reported COVID-19 cases, and the residents there, or at least some of them, believe they are safe. Is this a case that hospitals maybe don't have access to the tests in those areas? Or how should we continue to encourage these communities to stay home, Minnesota, and practice the social distancing we've been talking about?
Yeah, I don't think that that's an uncommon notion among people who live in areas that haven't been affected yet. But I think we all need to operate under the assumption that no one and no place is completely safe from this. When it comes to rural areas, I think it's helpful to see that there are rural places that have started to light up the map when we look at where the pandemic is spreading. And so being in a rural area and being in a county that doesn't have any positive tests yet is not in and of itself a reason to believe that you're safe. You may, as you say, John, have cases there that just haven't been tested yet. Part of that is access to testing. Rural areas really struggle with access to testing. There are some new tests coming down, and rural areas are going to be prioritized for that because they don't otherwise tend to have big labs where they can do their own testing with the tests that we have now. So it could be that people have it and aren't being tested. People may have it and be asymptomatic, or it just may not have gotten there yet. But with rural areas, no rural areas completely isolated. We're all interconnected in one way or the other, the way that our economy and our society works. And so I think everyone needs to believe that no one is completely safe here.
Thank you. I guess just in general, we have a lot of questions, understandably, about what therapies or, the silver bullet, what type of vaccines are being worked on around the world. And I'll kind of fold in another question that kind of comes with that is that, well, I guess first let's just handle like maybe the therapies or vaccines just from your respective readings or things like that. What are things that are on your radar? And I'll start off with Ryan.
Sure. Well, the big one that everybody is seeing a lot in the media is hydroxychloroquine, potentially with or without azithromycin. And I've seen some writings about possibly using zinc in combination with hydroxychloroquine. So again, this is one of these conceptual issues. Conceptually, hydroxychloroquine has the ability to prevent viral replication if it gets inside the cell. But we don't have a lot of real world data on this, and that's the really important thing. It's important because the drug actually does not have zero risk of other side effects. There are a lot of potential side effects. The rates of those are generally low in the populations they've been approved for use in, but there's great potential for side effects. And if you scale that out over millions of people, we'll see bad side effects from hydroxychloroquine. You can be sure of it. There are trials underway to test this. One of the main trials in the country, I believe, is being led at the University of Minnesota to see whether or not this particular medication can help reduce the severity of infection. There are also colleagues in Minnesota who are thinking about trying to do this prophylactically in healthcare workers. For that particular question, there's absolutely no data that I'm aware of that shows that it's beneficial, which is why the research is necessary. There was one study in France that was published recently and looked at this question, and Craig and I were talking about this the other day, and I think both kind of felt that the results were not very encouraging. The overall mortality rate in that study was right in line with everything we've been seeing, so it didn't seem to have reduced mortality, and there were some potential problems with the methods in the study in terms of who were included and excluded from reporting. So I think right now the best thing we can do is socially isolate and wait in regard to that medication. And vaccines are 12 to 18 months down the road, so that's not going to be a quick cure for us. I'll maybe stop with that, see if others want to interject. One additional thing I would say is beware of scams in this environment. If you see somebody that has a proven cure or prevention strategy for COVID-19, don't spend any money on it. None of that is really out there. Cheap things like vitamin C, if you feel better taking that, you could do it, but there's no data about vitamin C in COVID-19 infection.
Yeah, I would just, add the, with the vaccine development, it's important that it be done properly, and that, the very first studies of the first vaccines being developed are starting to happen, and those are safety trials. And basically, it's a matter of administering the vaccine to a few people just to make sure there aren't any big problems that exist with that. But then, really the process of doing studies that demonstrate that the vaccine is safe and effective when used in large populations, those are obviously difficult studies to do that require a lot of subjects. And we have groups at the university here who are working to coordinate studies like that so that we can have good data. Many of you will be familiar with what happened in the 1970s with the swine flu vaccine, when in what was thought to be a pending developing pandemic of swine flu, of influenza vaccine was developed and rushed into circulation, and ultimately it was shown to have some significant side effects in terms of being associated with Guillain-Barré syndrome. And so this was an unanticipated impact of the vaccine that had some public health implications. So we don't really want to rush a vaccine into production that could do more harm in the long run than it prevents. And so I think we have to just be patient and let the scientific process play itself out, both with respect to the treatments and the development of the vaccine as well.
You know, and then kind of in that vein, as far as you mentioned, vaccine 12, 18 months out, best case, you know, scenario. As far as a lot of questions have come in kind of about, and it's in the media as well, as like, you know, when can we get back to normal or start limiting the social distancing that we're doing right now, or the stay at home orders. Just kind of more from a scientific standpoint, is it from your respective opinions, is it just more of an issue of like needing to test more of the population just to be able to truly know where hotspots are, or a lot of the things that are coming out in the media now about a certain percentage of asymptomatic people carrying the virus unknowingly, is as far as like starting to get back to normal, is in your opinion, is that more of a matter of getting more tests out in the public? And I'd open that up for anyone.
Well, I can start. I think, yeah, testing is huge right now. We need to have a better understanding of the actual numbers, and there are almost no real data on asymptomatic carriage. A lot of it is based on anecdotal reports. We saw this play out in the NBA, where players who played against each other transmitted the disease while the infected individual was asymptomatic. I think the mayor of Miami was another anecdotal situation of somebody who tested positive multiple times, but never developed any symptoms. Understanding that dynamic is important, because that tells us how much is out there that we won't be able to see. And in terms of getting back to normal, we just need time to see what those results show. I've used the analogy with people recently, it's especially fitting for people from Minnesota, as, you know, trying to drive out of a skid on icy roads. We're in a skid right now, and you have to react very carefully to drive out of that rather than hit the ditch. Overreaction and underreaction can both be very harmful. And on that topic, I'll say that I've been in communication with some colleagues who are economists at the university, and they're starting to try and take infectious disease models and add economic variables to those models to try and figure out how we best balance social distancing in relationship to maintaining as healthy of an economy as we can in the long run. But I think one thing that is clear is that doing absolutely nothing would have been a total disaster for the economy in the short run and the long run. So it's finding that balance will be tricky, and we're working on it.
I think to build on Ryan's point, I worry that sometimes the political discourse around this, it makes it seem as though we can either do this social distancing to curb the pandemic, or we can open our economy, and that these things are mutually exclusive. But I would say we can't have a functioning economy without having people who are healthy and safe from disease to some extent. And we also need a functioning healthcare system. And so these things have to work hand in hand. I understand the impatience. I understand wanting to get back to real life. And I understand the true economic impact for people who have already lost their jobs. And yet I think we need sound public health knowledge to inform the economic way forward.
Carrie, I'm gonna tee up a question for you, as far as a listener asks if you have any recommendations on organizations or resources that you've been seeing as far as that can help counter the negative effects of social isolation and loneliness, whether rural, urban, suburbs. Are there any organizations that you look to as far as kind of either tips on breaking down that social isolation?
I'm going to give a two-part answer. The first part is just this immediate feeling of loneliness and isolation that many of us might be experiencing from having to not do all the things that we're used to doing. And for that, I think there are an unbelievable number of resources if you're able to get online and you can see all of these things where people are doing fitness classes via Zoom and happy hour via Facebook Live or Zoom, or social media and media platforms are clearly doing well in this context. But I think there's a lot of creative ideas out there. It's been really, really fun to see the way that people have engaged with technology. And so I don't think that you need to go to any one organization to see best practices for that. I think you can simply turn to just about any organization that used to operate in the real world to see what they've done to pivot to the virtual world. The second part of my answer is the part where I get much more concerned, and that's for the long-term trajectory and the people who are already isolated and lonely. And here I think we need real structural change. I think we need bigger change going forward. I think there'll be a lot of change that comes out of this pandemic. But if some of that is change that helps the way that we can connect with one another, I'll be really happy. And for that, I'm thinking, again, I'm mentioning all of these things about how we can connect with one another virtually, but there are lots of people who don't have access to internet. In Minnesota alone, 17% of households in greater Minnesota don't have reliable Wi-Fi access. And so they're kept out of all of these virtual ways of connecting. So one thing we can do is think about how to expand the broadband map, how to make access more equitable. But we also need to think about the places where people are quite literally isolated from society. Nursing homes, assisted living facilities, prisons, jails. Where are places where people tend to be much more isolated and lonely in general, and today are being told you can't have visitors, you can't have people coming in. And so thinking about ways that we can integrate folks across different facets of society is really, really important, and I think really urgent. And I also think some of this isn't rocket science. It's a matter of picking up the phone and calling someone, sending a letter in the mail. I love hearing Craig talk about how mail isn't all that dangerous here. I've been sending a lot of mail myself. And just thinking about the sort of connections that are meaningful for you, those are going to be meaningful for other people to receive too.
Great, thank you. Ryan, this next one's for you. We're getting a lot of questions about the intersection of COVID and you've been talking about pre-existing conditions, but the intersection of COVID and diabetes. And just from scanning one of the questions, one person had a question about if there's anything that's coming out as far as, you know, diabetes 1 versus diabetes 2 and COVID. But what's your take on, I guess, diabetes first specifically, and then also any other pre-existing, I know just in general, it's like if you have one of these conditions, it's you're at higher risk, but a lot of questions around diabetes and other things.
Sure. Well, the early data does suggest that if you have diabetes, to my knowledge of any type, you're at an increased risk. So this is a group of individuals, I would say, that should really be very cognizant about social distancing, and people in and around them, family and friends, should be careful about doing anything that puts them at risk. In terms of type 1 versus type 2, I can't think of any specific biological reason why one would be very different than the other. Type 1 is very rare, maybe 5% of cases. Type 2 is about 95% of cases. But more generally, people with type 2 diabetes certainly tend to have a lot more cardiovascular disease. It's also true to some degree of type 1 versus somebody who's diabetes free. But definitely type 2 diabetes comes with more cardiovascular comorbidities. And we know that cardiovascular disease, for the aforementioned reasons when I spoke earlier, puts you at higher risk. So there may be some reason to believe that type 2 is potentially worse than type 1. But overall, I would approach diabetes as diabetes and putting you in a high risk group, and just be careful. And probably the biggest thing to be thinking about in that group is making sure you have medications, and maybe finding ways to get medications without having to leave the house. Family and friends can help with that in certain circumstances. You can have a surrogate pick up a medication, or you can use mail order. And the advantage of mail order is that you can get, I believe, a 90-day supply. So that gets you a larger supply and again reduces the need to potentially go out. I've been concerned about supply chain shortages for insulin in the long run. There's no evidence of that at all at the current time, and everything I'm reading is that supply chains are intact. But I think hoarding is never a reasonable thing to do, but having a responsible extra supply of insulin makes perfect sense in the current context.
Thank you. Craig, I wanted to circle back. You had talked earlier about food and, possibly like the COVID virus, staying on food. We got a few follow-up questions just as far as, whether it's valid or not, some of the recent articles about, how long does COVID live on plastic? How long does COVID live on steel, other surfaces like that? With the same principles that you were talking about with like food, apply on surfaces, and then it just gets back to, like you were talking about, continuing the focus on washing your hands and avoiding your face and things like that. Hoping you could speak a little bit more on that.
Well, with viruses, viruses aren't living in the way that we typically think about a lot of things as being alive. The virus itself is a genetic material surrounded by its little coat, and it may persist, but it doesn't actually do anything until it gets attached to a living cell that it can then enter and then begin to take over the machinery of the cell to reproduce itself. And so again, when we think about environmental contaminants, we have to think about how is that virus getting from that surface into a tissue that it can cause an infection from. So there are a number of studies where they have demonstrated the persistence of viruses and infectiousness of viruses over a period of time. But again, the key issue is, what does that really mean in terms of transmission? So in some studies that have been done, where they've gone in and tried to look at maybe some re-aerosolization of the virus. So you have a contaminated surface, and then what is the possibility that the virus, sort of can be blown off of the surface up into the air where then you could subsequently breathe it. Typically the places where they've found aerosols with virus off of contaminated surface have been in settings like in a changing room in a hospital where people have been working around patients with coronavirus, and then they are taking off all of their protective gear. During the act of disrobing from the protective gear, they may be putting virus out into the environment. But that's a very limited and special setting. And probably, the cruise ship situation is a very unique setting as well, where you've got many, many thousands of people in a very small space. And in a setting like that, where you have a lot of people repeatedly exposed to environmental surfaces, the potential for environmental contamination, could be increased in that setting. But when we're talking about sort of exposures to environmental surfaces that may be very, casually contacted and then say delivered into the house, there's not going to be probably a lot of virus present on the surface to begin with, and then again, the mechanism for getting it into your respiratory tract has to be looked at. So I think, there just really is no evidence at this point that packaging materials, food items, really are contributing to transmission of this virus as we see it.
Thank you. And I think one kind of larger question for the group, maybe from the literature that you've been reading, is do we understand the role of recovered individuals in building herd immunity to COVID-19, and any thoughts on antibody testing?
Well, I think the issue right now, we don't really, I mean, we fully expect that recovered individuals will likely be immune, at least for short term, but, in all likelihood for long term, but that hasn't fully been established. An antibody as a marker that you have been infected and responded to the virus is traditionally something that is used as a marker of protection. And so I think over the next few months, as these antibody tests become available and used, we will learn much more about both how widespread this virus infection has been and whether that information could be useful in guiding recommendations about, people with antibody, and what role they might play in helping us move forward.
Craig summarized it very nicely, and I would just add that in the short run, I don't think these tests are of much value to the broad public. As speaking with a journalist in LA recently, and they have some antibody tests now available through certain health systems for $250 a test. And, not everybody's going to be able to easily go out and buy that test, especially if you have a large family and you want to get your whole family tested. In the current situation that they're in, with social distancing and a lot of stay-at-home orders in place, it doesn't matter what your result is. And we know almost nothing about false positive, false negative rates. So even the result of that test does not necessarily yet give you great confidence in whether you do or do not have the infection. In time, it will probably change, as Craig was saying, where it will become very important. What I'm curious to watch for is, how do we handle the mass production of many different kinds of antibody tests that aren't always going to give us the same answer to the same question. There are dozens of of businesses trying to produce them right now, and a lot of university laboratories as well, but there's not a lot of concerted effort so that people are trying to produce a test that will give us the exact same answer.
Well, I think we're coming up on 1 p.m. Central. So what I'll do is just maybe starting off with Carrie, I just want to restate, because I know some people have asked or jumped in late, is that I think one of the initial recommendations from this group, as far as kind of the trusted sources, is the CDC, the Minnesota Department of Health, Public Health, the School of Public Health at the University of Minnesota has some great resources as well. But just in closing, and we'll start off with Carrie, just anything that you just truly want to reinforce to those listening today, or anything else to add?
Sure. Well, thanks for spending this time with us. I just want to say, I think the irony of this is that it's showing how our connections to one another put us at risk, but also how much we need one another. And I think there's a lot we need to do in this current moment to handle the emergency situation. But I hope long-term we can value the people who are really stepping up as heroes here: childcare workers, custodians, nurses, people delivering home-delivered meals, so many others. I really hope that this helps us to rethink the way we structure things going forward. And most importantly, just take care of yourselves and one another.
Thank you, Carrie. Ryan, you're next.
Sorry. I think an important issue is to be flexible as we go forward. This is unprecedented. There are some things we know very clearly that we need to do in the short run, but this has been changing moment to moment ever since the beginning, and that's going to happen for a while. So I think bear with public health professionals and scientists as they try and help chart the course, because things will change over time for good reason. That's not necessarily a reflection of poor information. It's a reflection of the changing dynamic of the pandemic.
And Craig?
Yeah, no, I think there have been a lot of good things come out of this in spite of all of the bad thing. And as Carrie said, you know, sort of a new appreciation for sort of what we are risking losing will help inform the investments that we make as a society going forward. I do want to especially call out, though, the great collaboration between the university and the state of Minnesota, the Minnesota Department of Health, and all of the work that has been going on jointly behind the scenes to help really you know, provide for a foundation for the recommendations that are being made in the state and how to move forward. And I really appreciate the work of the governor and the commissioner of health in really being that strong and credible voice for how we move forward with this.
Thank you so much. Thanks to each of you for taking time out of your busy schedules to join us for this webinar today and take questions from our audience. I know, especially to those who submitted questions, lot of questions. So we tried to get through as many as possible and kind of cover the big buckets. But this will be informative just because I know our colleagues at the School of Public Health want to know what's on people's minds as well. And so this will help as far as the information that the University of Minnesota can put out there in the future as well. I am going to just share one last time the screen that has the vanity link to the School of Public Health page, z.umn.edu, SPH April 6. And just want to thank each of you, our panelists, but then also our alumni, students, friends of the university for joining us online today. My name is John Ruszek with the Alumni Association. Thank you. Hope to see you on a future webinar, and be well.